Welcome to the White Coat Classroom. In this module of pathology, we would be studying about jaundice. So, without wasting time, let's get started. So, by the end of this module, we would be understanding what is jaundice, what is the mechanism of bilirubin, how normally bilirubin is metabolized inside our body, what is conjugated bilirubin, what is unconjugated bilirubin, what are the types of jaundice, and the features of each and every type of jaundice, and in the last, we would be summarizing all these things. Starting with our first slide on jaundice. What is jaundice? Is jaundice a disease or manifestation of disease? Yes, correct. Jaundice is not a disease in itself, but it is a manifestation of many different diseases. So, normal bilirubin level in our body is approximately 0.1 to 1.2 mg per dl. The total bilirubin, the upper limit is approximately 1.2 mg per dl. But when the bilirubin level increases beyond this level, it is called as hyperbilirubinemia. And when the hyperbilirubinemia is such that it starts to manifest clinically, the clinical changes are seen in person's body, like there is yellowish discoloration of sclera or skin or mucous membrane. When it starts to appear, that is called as jaundice. So it is a clinical condition characterized by yellowish discoloration of sclera, skin and mucous membrane due to elevated levels of bilirubin in blood, and it becomes noticeable when serum bilirubin level is above 2 or 2.5 mg per dl. Starting with normal bilirubin metabolism, let's understand how bilirubin is metabolized inside our body. So, the first question is, from where does the bilirubin comes? Yes, correct. Bilirubin is formed inside our body from the breakdown products of RBC. So when there is breakdown of RBC, the hemoglobin molecule is released, and the hemoglobin molecule is made up of two major components, the heme component and the globin component. Globin component is nothing but the protein chains. So globin would be broken down into amino acids, and those amino acids would be utilized by our body, while this component is the heme component. The heme component have two major parts, the iron part. The central one is the iron atom, and surrounding which we have these ring structures. These rings are called as protoporphyrin ring, the 9-membered ring, the protoporphyrin rings. So the iron of the heme is reutilized by the body, while the protoporphyrin rings are broken down in body, and these protoporphyrin rings are converted into a compound called as biliverdin. This is a green colored compound in a linear structure. This is biliverdin. And this biliverdin is again converted into a yellow colored compound called as bilirubin. So the bilirubin is obtained from hemoglobin breakdown, as hemoglobin is broken down into two components, the heme component and the globin component. From the heme component is having iron and protoporphyrin rings. So iron is reutilized back, while the protoporphyrin rings are converted into biliverdin, a green colored compound, which is again converted into a yellow compound called as bilirubin. Now, after understanding the formation of bilirubin, we would be understanding the subsequent steps. So in this figure, what you are seeing is the sky blue colored structure is the outline of liver, inside which the brown color hepatocyte is shown, from which are arising the green colored biliary structures, the biliary tree, and that is further draining into duodenum, which is outlined with black color, and the red color is the vasculature. So, due to breakdown of RBC, bilirubin molecules are formed, and those bilirubin molecules now starts appearing in blood. So, This is the bilirubin molecule which starts to appear in blood. Now, this bilirubin molecule is called as unconjugated bilirubin, as the process of conjugation has not occurred till yet. So this is unconjugated bilirubin molecule. Now, the properties of unconjugated bilirubin are: the unconjugated bilirubin is water insoluble. So, if it is water insoluble, would it be easily floating in blood or not? Yes, correct. It won't be, as the blood is polar and our bilirubin compound is non-polar, so it needs a substance that would be stabilizing it and through which it would be easily moving in blood. So it would need a protein molecule. So usually albumin protein combines with it. So this is the albumin protein which combined with the unconjugated bilirubin. Now this is again unconjugated only. Just it is protein bound. Previously it was free unconjugated bilirubin. Now it is protein bound unconjugated bilirubin. Now as this is covered with albumin molecule, which is a water soluble molecule, so it would be easily floating or it would be easily moving in blood. So now this protein and unconjugated bilirubin complex moves, and this moves towards the liver, and the further steps occurs in liver. So what occurs is the complex of protein, that is albumin, and unconjugated bilirubin complex moves inside the liver, and in the hepatocyte there is an enzyme called as UGT, glucuronil transferase enzyme. What it does is it converts the unconjugated bilirubin molecule into a conjugated bilirubin molecule. It just adds a compound. It adds a compound and make it conjugated bilirubin. So the product which we obtained is a conjugated bilirubin molecule. This is a conjugated bilirubin molecule. So revising the steps, what we have seen is there was unconjugated bilirubin molecule. In the hepatocytes, albumin is produced, and that albumin is transported via blood, and in blood it comes into circulation and combines with unconjugated free bilirubin, and the product which is formed is again unconjugated but bound bilirubin, which is bound to plasma proteins. Now this complex via blood again moves into hepatocyte. This complex moves into hepatocytes. In the hepatocytes there is an enzyme called as UGT, glucuronil transferase enzyme, which converts this unconjugated bilirubin into a product which is called as conjugated bilirubin. So this is the conjugated bilirubin which is formed inside the hepatocyte, and in the hepatocyte, the drainage system of hepatocyte is the biliary tree, this green colored structure. So via the biliary tree, it is transported into duodenum. So in duodenum, what we get is the conjugated bilirubin. Now what occurs is majority of this conjugated bilirubin is transported further in the intestines, in the small intestine, in large intestine, and it is excreted out via feces, while a small part of it is circulated back via enterohepatic circulation back into the liver. So this is the pathway of enterohepatic circulation. Now let's understand about conjugated bilirubin and unconjugated bilirubin. As we have seen, the unconjugated bilirubin was water insoluble. As that was water insoluble, that needs for the transport in blood, that needs a transporter, and that transporter was albumin. So it is bound to albumin. It is water insoluble. The first point is it is water insoluble. It is bound to albumin, and it is transported in blood via in the form of bound to albumin. Is it clear? Now about the direct bilirubin. The direct bilirubin or the conjugated bilirubin is formed after the process of conjugation, and in the liver. After the process of conjugation, what occurs is the unconjugated bilirubin, which is water insoluble, gets converted into a water soluble compound. So the conjugated bilirubin is water soluble. So as it is water soluble, it doesn't need any protein or transporter to transport it in blood, so it is not bound to albumin, and it is transported freely in blood. Clear? Now, as we know, the unconjugated bilirubin is formed by breakdown of RBC. The site of formation is reticuloendothelial system from hemoglobin breakdown. While the conjugated bilirubin is formed in liver and it comes freely in plasma. So it is formed in liver. Now, as the kidney gets its blood supply, so for any compound to come in kidney, that compound must be water soluble, as kidney would be getting it via the blood, as indirect bilirubin or unconjugated bilirubin is water insoluble, so it cannot be excreted in urine. Wait, you would be asking, after bounding to bilirubin, would it appear in urine? But as we know, albumin is a large size protein, and that albumin size is such that it cannot pass the glomerular filtration membrane. So if it is in the bound, if the bilirubin, unconjugated bilirubin, is bound to albumin, it won't be appearing due to its large size. While in case of free unconjugated bilirubin, it is insoluble in blood, so it won't be appearing. So in both these conditions, in case of indirect bilirubin, it won't be appearing in urine. While the direct bilirubin is water soluble, so it can be excreted in urine. Now there is a lab test called as diazo reaction, or in diazo reaction the direct bilirubin reacts directly and the changes occurs, while in case of indirect unconjugated bilirubin, it needs an alcohol. That's why it doesn't react directly. That's why it is called as indirect bilirubin, while the conjugate is called as direct bilirubin. Now the next point about toxicity, as we have seen, the unconjugated bilirubin is water insoluble but lipid soluble. Due to its lipid solubility, it can cross the blood brain barrier. In neonates or newborn, there is weak blood brain barrier, so it crosses the blood brain barrier and it can stain the basal ganglia or neuronal tissue, that is called as kernicterus. So indirect bilirubin toxicity can cause kernicterus, while direct bilirubin or conjugated bilirubin is lipid insoluble, so it cannot cross the blood-brain barrier and it is non-toxic. So that's it about conjugated bilirubin and unconjugated bilirubin. Now let's understand the types of jaundice. Jaundice is classified into three major types, that is pre-hepatic, hepatic and post-hepatic. So let's understand them. Now let's understand the types of jaundice. As we know, pre-hepatic jaundice is also called as hemolytic jaundice. Pre-hepatic jaundice means the changes which occurs before the bilirubin enters the liver. So what could be the causes? Hemolysis. If more and more of RBCs are getting broken down, so what occurs is more and more bilirubin molecules would form it. That is pre-hepatic cause. What occurs in hepatic causes? In the next step, what we see is these unconjugated bilirubin molecules moves into the liver and the process of conjugation occur. But in case of hepatic jaundice, what occurs is the liver is non-functional. In first condition, there is increased RBC breakdown, so more and more load of bilirubin. While in second condition, the liver functioning is abnormal, so the process of conjugation is not proper. While in case of the third, that is post-hepatic means the problem is occurring somewhere after the process of liver, that is in the drainage function. So this is the drainage system. In the post-hepatic cause, if there is obstruction anywhere in this pathway, that is called as obstructive jaundice. So this is the third type of jaundice. So based on the pathophysiology, it is pre-hepatic, this is hepatic cause, and this is the post-hepatic cause of jaundice. Now let's learn about each of these individually. The first one is hemolytic jaundice, that is pre-hepatic jaundice. In hemolytic jaundice, what occurs is more and more of RBCs are getting broken down, so more and more of bilirubin is getting formed. So what could be the cause? The cause could be hemolytic anemia, autoimmune hemolysis, or it could be due to infections, toxins, incompatible blood transfusion, or any other condition which is causing more and more of RBC breakdown like G6PD deficiency. The next one is hepatic jaundice, which is also called as hepatocellular jaundice, in which the functioning of liver is not proper or not up to the mark. What could be the causes? The causes could be hepatitis, it could be viral hepatitis, it could be alcoholic hepatitis, it could be drug-induced hepatitis or drug-induced liver injury, it could be cirrhosis, or it could be genetic or metabolic disorder. The next cause is post-hepatic, that is obstructive cause. The obstruction most commonly is due to gallstones, or it could be carcinoma of head of pancreas, cholangiocarcinoma, or strictures in bile duct, or cholangitis. It could be primary sclerosing cholangitis or secondary cholangitis. So it could be any cause which is causing obstruction. Now let's learn how you can differentiate these three types of jaundice based on clinical features in basic lab reports. Now, starting with it, as we know, the cause of pre-hepatic is RBC destruction. For hepatic, it is hepatocyte dysfunction, while post-hepatic or obstructive, there is obstruction. Much simple. Now, tell me which type of bilirubin would be raised in pre-hepatic jaundice. Yes, correct. More and more of RBCs are getting broken down, so unconjugated bilirubin will be high. In case of hepatic jaundice, which type would be there? Yes, if hepatic injury is there, so some of the hepatocyte would be functional and other would be non-functional. So those which would be functional, those would be producing conjugated, while the unfunctional would not be able to cope up with the function of conjugation, so still more and more of unconjugated bilirubin molecule would be remaining. So both conjugated and unconjugated would be seen. While in case of obstructive jaundice, what is occurring is obstruction is after the hepatic change is occurring, that is after the conjugation process there is bile flow obstruction, so the type of bilirubin raised would be conjugated bilirubin. Now, as we know, unconjugated bilirubin is not able to appear in urine, so urine would be normal color in pre-hepatic jaundice. While in case of hepatic jaundice, it would be dark color, while in case of post-hepatic jaundice, it would be again dark color due to conjugated bilirubin which is appearing. So, in unconjugated bilirubin, that is pre-hepatic, more and more of bilirubin are there, but it is unconjugated bilirubin, so it won't be able to come in urine as it is water insoluble. The next one is hepatic. In hepatic, the few molecules would be conjugated, few would be unconjugated. So due to conjugated bilirubin, these conjugated molecules would be appearing in urine, and that would be imparting a dark yellow color. While in case of obstructive jaundice, what occurs is if there is obstruction over here, suppose if there is obstruction over here, so the mechanism is completely normal till here before the obstruction, so more and more of conjugated bilirubin is formed, but it is not able to drain here. So if it is not able to drain here, these bilirubin molecule would backflow, and due to that backflow it would go in kidney, and from kidney it would appear in urine. So the urine would be dark colored in case of obstructive jaundice. Now let's understand the findings in case of stool. In case of pre-hepatic jaundice, unconjugated bilirubin is increasing. It is increasing such that it is beyond the capacity of liver to conjugate, but liver is still functional, so liver is still conjugating, the normal the normal quantity of molecules which it usually leads to which it usually conjugates. So normal amount of conjugation is still there, so the stool colored would be normal in case of pre-hepatic. While in case of hepatic, few process of conjugation is occurring, and in few hepatocytes it is not occurring, so it could be normal or it could be pale in color. While in case of obstructive or post-hepatic, what is occurring is a lot of conjugated bilirubin is still getting formed, but it is not getting excreted in GIT. If it is not appearing GIT, it won't be appear in stool. So stool colored would be pale in case of obstructive jaundice. Now, let's understand about the markers. These are the clinical cardinal features from which you would be identifying. If there is history of RBC breakdown, it is pre-hepatic. Along with that, if the patient is having normal colored stool or normal or slightly yellowed urine, that is a case of pre-hepatic jaundice. In case of hepatocellular jaundice, there will be history of hepatic infection or hepatic cirrhosis or any other hepatic dysfunction. In that condition, the urine would be dark colored and stool could be normal or pale colored. While in case of obstructive jaundice, there will be history of obstruction. Along with that, urine would be dark colored and stool would be pale or clay colored stool. This was the clinical picture. The next clinical picture is about the point of itching. The conjugated bilirubin is in case of obstruction, what occurs is the conjugated bilirubin level increases, and that conjugated bilirubin level, when appears in skin, that causes skin itching. That's why itching is prominent in case of obstructive jaundice. That's why, as it is related with conjugated bilirubin which is appearing in skin, so in case of pre-hepatic, there will be no conjugated bilirubin, while in case of hepatocellular, it may be present, but it is a typical feature of obstructive jaundice. Clear? Now the next point is anemia and reticulocytosis. Anemia and reticulocytosis is due to anemia is due to RBC loss, and reticulocytosis is in the response of body for that loss. So it would be high in case when there will be RBC breakdown. So that is common in case of pre-hepatic type. Now the common causes are hemolytic anemia in case of pre-hepatic, while it is hepatitis cirrhosis in case of hepatic cause, or gallstone or tumors in case of obstruction. So this was all about the clinical picture. Now let's understand the basic test from which you would be identifying, that is serum ALT level, AST level, alkaline phosphatase and GGT levels. So let's understand its concept. The AST levels and ALT levels rises when there is a hepatic injury. Just remember, if there is hepatic injury, the hepatocytes normally contains a lot of AST and ALT, that is SGOT and SGPT. So hepatocytes contain SGOT and SGPT. If there is injury to hepatocyte, what occurs is, due to injury to hepatocyte, the content would come out in blood. So the leakage of the hepatocyte content would be there, and that content would appear in blood, and that content is AST and ALT. That would be seen in case of hepatic injury. While serum alkaline phosphatase and gamma glutamyl transferase, these are present in the biliary ducts. These are present in cells which are lining the biliary pathway. So when there will be injury to biliary system, these would be coming out in plasma, and that would be appearing in blood. So serum ALT, AST level would be normal in case of pre-hepatic or hemolytic type, while it would be raised in case of hepatocellular, it would be highly raised, and in case of post-hepatic, it could be mildly, or it could be normal or mildly raised. While serum alkaline phosphatase, it is a marker of biliary tree injury, so it would be normal in case of pre-hepatic. It may be rising slightly in case of hepatic injury if there is subsequent injury there, or in case of post-hepatic or obstructive jaundice, it would be mildly raised. So that's it about the types of jaundice. and thank you so much for listening. Now, let's summarize what we have seen in this module. In this module, we have seen what is jaundice. Jaundice is yellowish discoloration of skin, sclera, mucous membrane that occurs due to hyperbilirubinemia. Next in the line, we have seen the normal bilirubin metabolism, in which we have studied how bilirubin is obtained. Bilirubin comes from breakdown of RBC. Due to breakdown of RBC, the heme component and globin component are obtained from the heme component. The heme component breaks down into iron and protoporphyrin, and that protoporphyrin gets converted into biliverdin, and biliverdin finally gets converted to bilirubin. This bilirubin is unconjugated bilirubin. In the plasma, it combines with protein and it forms protein bound unconjugated bilirubin. Next in the line, this complex moves to the liver. In the liver, in the hepatocyte, there is enzyme UGT glucuronil transferase, which converts this non-polar compound into a polar compound, and that polar compound is conjugated bilirubin. That conjugated bilirubin is excreted via biliary system into intestine, and that conjugated bilirubin is responsible for the dark stool color or the dark feces color. After that, we have seen the difference between conjugated bilirubin and unconjugated bilirubin. Unconjugated bilirubin is highly highly lipid soluble and water insoluble, due to which it needs a transporter in blood. That's why it is transported along with albumin protein, and due to this lipid solubility, it can cross the blood-brain barrier in neonates. That's why it can cause kernicterus in neonates. And due to its water insolubility, it is not excreted in urine, while the conjugated bilirubin is lipid insoluble, while it is water soluble, so it is excreted in urine also. Next in the line, we have seen the types of jaundice. The three major types of jaundice are pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice. The major cause of pre-hepatic jaundice is hemolysis. The cause for hepatic jaundice is hepatocellular damage, while for post-hepatic it is obstruction. In pre-hepatic jaundice, what we see is the unconjugated bilirubin level rises, while the conjugated bilirubin level is approximately normal. In hepatocellular injury, both unconjugated and conjugated bilirubin level rises, while in obstructive type of jaundice, conjugated bilirubin level rises. Next in the line, we have seen the markers of injury. The AST and ALT are markers of hepatocellular damage. That's why they increases in level in condition of hepatic jaundice, while gamma glutamyl transferase and alkaline phosphatase levels are raised in condition of obstruction. That's it about jaundice. Thank you so much for listening.